The topic of the lecture is Ophthalmologic Anesthesia. My name is Charles Lin. I'm an assistant professor in the Department of Anesthesiology at the University of Pittsburgh School of Medicine. I have no disclosures. The objectives for today's talk is to review ophthalmologic anesthesia, to review retrobulbar and peribulbar blocks, to review open eye injuries. Let's talk about the major components of the eye. The sclera. This is the fibrous outer layer that gives the eye its shape. The cornea. The cornea is the anterior portion of the sclera, which is transparent and allows light to enter the eye. Next, we have the iris. The iris includes the muscles that control the constriction and dilation of the pupil, which controls the amount of light that enters the eye. Pupillary dilation is sympathetically controlled. Pupillary constriction is parasympathetically innervated. Next, we have the ciliary body. The ciliary body sits behind the iris. It makes the aqueous humor. The ciliary muscles which lie within the ciliary body control the shape of the lens. The choroid. This is the vascular layer of the eye. The internal and external carotid arteries supply blood to the eye. The central retinal vein drains the eye into the cavernous sinus. And last, we have the retina. This is the membrane in the posterior eye that converts light into neural signals. These signals travel to the brain via the optic nerve. Next, I will talk about ocular physiology. The aqueous humor. 66% of the aqueous humor is produced by the ciliary body. 33% of the aqueous humor is produced by reabsorption from vessels. The aqueous travels from the ciliary body posterior chamber to the anterior chamber, which bathes the lens and the cornea. Then it exits the eye via the trabecular network and the Schlemm canal. So when intraocular pressure is discussed, these are the factors. Number 1, scleral rigidity. Number 2, external pressure on the eye. And number 3, changes in intraocular volume. Based on this, the causes of increased intraocular pressure include the following. Number 1, any event that impedes aqueous humor drainage into the SVC. The events relevant to anesthetic care that can cause this include Trendelenburg position, coughing, straining, vomiting, laryngoscopy, and intubation. These effects can be mitigated with the administration of topical local anesthetic to the trachea. However, it is not reliable. The other causes of increased intraocular pressure include contraction of the extraocular muscles, including the orbicularis oculi, and pupil dilation because drainage is impeded via narrowing of the Fontana space. The last entity that is important to talk about with regards to ocular physiology is glaucoma. There are two types of glaucoma. One is open-angle glaucoma, otherwise known as chronic glaucoma. The open angle means that the angle between the iris and the cornea is open. The cause is usually due to trabecular tissue sclerosis, which impairs aqueous humor drainage. The other type is closed angle, otherwise known as acute glaucoma. The closed angle means that the angle between the iris and the cornea is closed. This can occur with pupillary dilation. One primary reason that glaucoma is important for anesthesiologists is because of some of the medications that we can administer. Anticholinergic use is concerning for worsening glaucoma. In one of the textbooks, atropine in usual doses including 0.4 milligrams is okay, according to the authors of Anesthesia and Ophthalmology. However, scopolamine should be avoided because it has more significant mydriatic effects. So if you have a patient with glaucoma, you need to do two things. One is to avoid overhydration, which can increase venous pressure and impede drainage. The other is to avoid hypotension, which increases the risk of retinal thrombosis. Next, I will talk about the anesthetic considerations and intraocular pressure. So when talking about intraocular pressure, it is important to think about several things. Number 1, intraocular versus extraocular surgery. For intraocular surgery, you need to maintain akinesia and you want to minimize any increase in your intraocular pressure. For extraocular surgery, the intraocular pressure concerns are less. In fact, the more important entity to consider is oculocardiac reflux, which I will talk about in a little bit. Next, volatile anesthetics. These can cause a dose-dependent decrease in intraocular pressure. The cause is multifactorial, including CNS depression, decreased aqueous humor production, increased aqueous humor drainage, and extraocular muscle relaxation. The IV anesthetics, including propofol, etomidate, opiates, and sedatives, all decrease intraocular pressure. However, it is important to note that etomidate causes myoclonus, which can be dangerous in a ruptured globe. Next is ketamine. There are conflicting results, possibly due to different methods of measuring intraocular pressure. One study demonstrated that IV ketamine, 2 milligrams per kilo, did not increase intraocular pressure in adults. Another showed no increase in children and were the same as the intraocular pressure with volatile anesthetics. However, another study demonstrated that intramuscular ketamine, 5 milligrams per kilo, increased intraocular pressure 5 to 15 minutes after its administration in children. Nevertheless, it is important to note that you may want to avoid ketamine because of the risk of causing nystagmus. Succinylcholine. Succinylcholine increases intraocular pressure by 8 millimeters of mercury 1 to 4 minutes after its administration. There have been many attempts to blunt this increase in intraocular pressure. However, the use of beta blockers, a small dose of succinylcholine before the induction dose, IV lidocaine, these have all been tried, but none have demonstrated reliable benefit. For non-depolarizing muscle relaxants, all of these medications decrease intraocular pressure by relaxing the extraocular muscles. The other ocular physiologic entity that is important for anesthesiologists to consider is the oculocardiac reflux. So the mechanism for the oculocardiac reflux is that the afferent arm is mediated by the trigeminal nerve. The efferent arm is mediated by the vagal nerve. The triggers of this reflux include pressure on the globe, traction on the extraocular muscles, and a retrobulbar block. This reflux can be manifested on the EKG via 1. Sinus bradycardia, 2. Junctional rhythm, 3. Ectopic atrial rhythm, 4. AV blockade, 5. Ventricular arrhythmias, and 6. Asystole. There are several methods to attempt to prevent the oculocardiac reflux. One is pretreatment with glycopyrrolate or atropine. However, you do want to be careful with atropine because its effects on the heart rate may be equally as severe, if not worse, than the actual reflux itself. And the management is to have the ophthalmologist release pressure. For the remainder of the lecture, I will talk about the following two topics: anesthetic options and anesthesia for unique ophthalmologic surgery. So, the anesthesia options, there are three. There is general anesthesia, there is retrobulbar block, and there is peribulbar block. For general anesthesia, you can either use an endotracheal tube or a laryngeal mask airway. An endotracheal tube minimizes the risk of aspiration. However, the benefit of a laryngeal mask airway is that it minimizes the risk of coughing and bucking on emergence. In pediatric ophthalmology specifically, general anesthesia is the most common anesthetic technique. Moving on to the retrobulbar block. The retrobulbar block was developed by Atkinson in 1936. The way the block is performed is that the needle tip penetrates the orbital cone created by the rectus eye muscles. The local anesthetic is deposited within the cone behind the eye. The orbital cone is hypothetical. No physical septum exists on cadaveric dissection to demarcate the borders. As you can tell on this diagram, you can note the final location of the needle and its location with regards to the posterior eye. The benefits of the retrobulbar block include low volume and a fast onset. However, the drawbacks include the needle tip is closer to the eye, and there is a higher risk of injecting local anesthetic into the inferior rectus muscle, which is a potential cause of postoperative strabismus. Next, we have the peribulbar block. The peribulbar block differs from the retrobulbar block both in depth and angulation. Repart reported in 2001 that injections outside the orbital cone spread into the cone, and injections within the orbital cone spread outside. This led to the development of the peribulbar block because it involves less angulation, less depth, and the needle is more parallel to the eye so that the local anesthetic is deposited close to the eye but not as close as a retrobulbar block. As you can see on this diagram, the needle tip is not in the posterior location of the eye. The way this is performed is the needle is advanced parallel to the eye toward the sphenoid bone. The benefit of this block is that it is safer because the needle tip is farther from the eye and brain. However, the drawbacks include the use of greater volume of local anesthetic and a slower onset. It is important as the anesthesiologist to note the potential complications of regional ophthalmic anesthesia. One of them is the oculocardiac reflux. Number 2, circumorbital hematoma due to a superficial hemorrhage. Number 3, retrobulbar hemorrhage due to a deep hemorrhage, and this can cause retinal ischemia and blindness. Number 4 is retinal detachment, which is due to injection into the globe, and this can cause blindness. Next is optic nerve damage. This is more likely with the retrobulbar block than with the peribulbar block, and this can also cause blindness. Next is epidural injection. This can occur if the local anesthetic is deposited within the optic nerve sheath. The volume can compress the optic nerve and cause blindness. The local anesthetic can also spread towards the optic chiasm and cause contralateral blindness by blocking the contralateral optic nerve. Next is post-block strabismus. This is caused by injection into the inferior rectus muscle. And last is intravascular injection, which can cause seizures and hemodynamic compromise. So the anesthesia for unique situations, we have 4 of them: open eye injuries, strabismus surgery, intraocular surgery, and retinal detachment surgery. The anesthesia for open eye injuries. First, is this patient a difficult airway? It is important to talk to the ophthalmologist because the patient may cough with an awake fiber optic. It is important to discuss with the ophthalmologist about alternatives such as topical anesthesia or an ophthalmic block for the surgery. It is also important to address the risk of aspiration. Patients with an open eye injury are often not candidates for an ophthalmic block due to the risk of eye content extrusion. And that is why a general anesthetic would be advised under the context of rapid sequence intubation and cricoid pressure. It is also important to address the risk of eye extrusion with the ophthalmologist. Coughing should be avoided to avoid eye extrusion. Succinylcholine produces minor increases in intraocular pressure, but has the benefit of optimal intubating conditions and minimal coughing. The other consideration with eye extrusion is an unrecognized difficult intubation, because hypoxia and hypercarbia can also increase intraocular pressure. Next is strabismus surgery. The concerns with this surgery relevant to the anesthesiologist is number 1, the oculocardiac reflux, and number 2 is the malignant hyperthermia risk. For that reason, succinylcholine should not be used because patients at risk for malignant hyperthermia also have other musculoskeletal disorders including strabismus. The other reason why succinylcholine should not be used is because the forced duction test can be affected. This test is used by the ophthalmologist to differentiate an eye muscle that is restricted or paralyzed. The ophthalmologist moves the eye by grasping the sclera with the forceps to assess the eye's passive movement. Unfortunately, succinylcholine can affect this test, so that's why it is advised not to use succinylcholine at least 20 minutes before the forced duction test. The last consideration for the anesthesiologist is postoperative nausea and vomiting, and this is usually due to the oculogastric reflux. You can reduce the risk with antiemetics, a propofol infusion used as a total intravenous anesthetic technique, or to minimize opiate use. Usually, the anesthetic is a general anesthetic. For intraocular surgery, the considerations for the anesthesiologist include controlling the intraocular pressure. This means avoiding hypercarbia. This also means using laryngeotracheal anesthesia or other means to avoid and to minimize coughing on emergence. The other consideration is to avoid movement. That is why it is prudent to use muscle relaxant during surgery. And the anesthetic is usually a general anesthetic. For retinal detachment surgery, the concerns for the anesthesiologist is intraocular pressure control, number 2, oculocardiac reflux, and number 3, it is to avoid nitrous oxide. Nitrous oxide can expand sulfur hexafluoride bubbles, which the ophthalmologist places, which can increase intraocular pressure. The peak rise occurs in about 20 minutes. That is why it is recommended that no patient who has retinal detachment surgery receive nitrous oxide for 5 days after the air bubble injection, 10 days after sulfur hexafluoride injection, or 70 days after perfluoropropane injection. The reason for this is that there is no predictable resorption time. And this is the conclusion of the lecture.